there are a few mechanisms that result in the failure. So previously I talked about the acquisitions of mutations that confer proliferative advantage, like additional FLT3-ITD mutations and so on. So if in case the progression is due to acquisition of these mutations that confer proliferative advantage, then we would obviously need to see if some of these acquired or mutations that evolved are potentially targetable. Say FLT3 mutations could potentially be targeted by FLT3 inhibitors, like the use of Ivosidenib on top of the treatment, right? Or some of these mutations could be targeted by addition of BCL2 inhibitors, for example, venetoclax, in addition to hypomethylating agents. So these are some examples. Or there are other co-occurring mutations that might confer resistance, like the presence of IDH1, IDH2 mutations. These could be targetable with the use of Ivosidenib, which is an IDH1 inhibitor, or IDH2 inhibitors like Enasidenib, or other newer agents in the pipeline. So these are some of the sort of mechanisms as well as ways we overcome it. These are sort of genetic mechanisms. And what about the immune dysregulations? As I've just discussed, checkpoint, the certain checkpoints, immune checkpoints are commonly dysregulated in patients with MDS, like PD1, PD-L1. And most recently, we know that TIM3 is basically one of the checkpoints that's also dysregulated in MDS, especially in high-risk MDS. So it's potentially targetable with addition of TIM3, anti-TIM3 monoclonal antibodies. I think Sabatolimab or MBG453 is one of the agents that has been discussed in many papers that were presented here at EHA and also last ASH. And this is one of the promising agents, although we are still awaiting later phase 2 and phase 3 data on various subgroups of MDS. I think that's one of the possibility. And these checkpoint inhibitors could be used in conjunction with hypomethylating agent and BCL2 inhibitors, like in triplet regimens. And the other checkpoint that's quite sort of impressive would be magrolimab, the anti-CD47. There are also other sort of immune checkpoint inhibitors inhibiting CD47, which is the don't eat me signal, all right? That's also dysregulated in MDS and also in patients with AML, especially these patients who harbor the TP53 mutation. So I think these are some of the mechanisms and also ways that we can actually deal with them.